the book of. So today, let me introduce myself. My name is Ijaz Hidayat. I'm the founder of the Book of Profian by Ijaz Hidayat, this channel and even this WhatsApp group. And working in Hamad Medical Corporation as a lead education Profian units and working as a Ecmo specialist and MCS. The part of the member of the MCS groups. MCS is the mechanical circulatory group, uh, which is composed of we are doing all the mechanical devices, clinical part, which was be controlled by the perfusionists like intra-aortic balloon pump, autologous salt saver, angiovac systems, extracorporeal membrane oxygenation, left heart bypass, right heart bypass, LVAD, and even the further the latest technologies in which we involve, like in a heart transplant, lung transplant. So all this specialty is going to be covered with the MCS. And today I will going to highlight about the Ecmo circuit emergencies. Ecmo mean extracorporeal membrane oxygenations, and we're going to talk the basics ECMO emergencies, which will be faced by the perfusionist and even by our ECMO specialist nurses or physicians. So before I'll start my presentation, I'll just need to tell you about that I don't have any conflict of interest. This presentation is purely based for to share knowledge, to share our experience, clinical experience among our perfusion allied health profession group. So it can be helpful for each other to share our experience, our mass things or our success things. So everything will be covered through this presentation. I will try to highlight about some good thing about the topic which I have chosen today. So the objective of today's my presentation is we will going to diagnose and treat about the pump failure, ECMO pump failure. Then we're going to talk about something about like air embolism, or we can say the air in the circuit, and how we're going to deal in the situation where we get the air in our extracorporeal circuit, and in case how we're going to deal and diagnose our the patient if our circuit, our ECMO console get failure. Then we'll talk about some oxygenator failure mechanisms, and of course going to discuss about the circuit rupture and accidental decannulation of the extracorporeal membrane oxygenation. So what is ECMO? ECMO is the extracorporeal membrane oxygenation. Extracorporeal means outside the body. If you talk about the human physiology, and you will see the blood circulation inside the body was maintained with the human physiology. Like we have two systems running in the body, like arterial and the venous system. So blue blood is getting into the right heart, and from the right heart, this blue blood was pushed through by the power of your vital organ like heart into the lungs, and from the lungs the purified blood, where the oxygenation and CO2 removal action happened, and then the oxygenated blood returned back into the left heart, and from the left heart it's going into the whole body. And now this mechanism will be connected with the outside. This things is happening, the oxygenation and ventilation part will going to be happened outside the body, is called the extracorporeal membrane oxygenation. And membrane is the lungs part will going to be covered by the artificial lung, we call the membrane oxygenator, and it work as a lungs actually. So the function of the lung was going to replace by the ECMO, the function of the heart going to replace by the ECMO. And the oxygenation, as I mentioned before, the process of getting the O2 into the blood and removal of the CO2 from the blood is going to happen in the membrane, and this all process is called the extracorporeal membrane oxygenation. ECLS is the extra life support, and as in the beginning, we prefer to go with the extra corporate life supports, and where we can use the complete heart lung machines and with the different devices. But now the modification happened, and we are trying to compact the things, and we come up with the ECMOs. So what is the pump failure? The major, what is the, they will going to talk about the definition of the pump failure. So this is the state of the no flow due to failure of the electrical pump drive pump head. So if you talk about the definition of the pump failure is no flow, no RPM. So I purposely keep this definition so you can ask me the question, but I just highlighted here. If we'll talk about the pump failure, mean no flow and no RPMs. If sometimes there is RPM, but there is no flow. Clear? So it can be the reason that maybe your probe is not connected properly. It can be the reason some
Yeah.
cannula can be obstructed there, and you are not getting the flow. But once you talk about the pump failures mean no flow, no RPM. So what can be the causes for the no flow and no RPM means pump head disengagement, as I mentioned. So this is like there is RPM, but your pump head was not properly engaged. This was disengaged. So there is a pump failure is one term where you are getting RPM, but you are not getting the flow. So other one is electrical motor failures. So it's mean once if the motor get failed, your machines get shut down, so you will not get the flow, you will not get the RPM. And the third is your battery failure, like no AC powers connected, and your machine was running on the battery, and sometime by the ignorance of the bedside ECMO specialist or ECMO nurse or ECMO physicians, so you ignored the AC connections, AC power connection with the consoles, and the time will come when your battery can get drained, and machine will going to be off, and this is called the battery failure. So no AC power, so no battery available, battery back available. So this can be the causes. The causes of the pump failures can be the pump head disengagement, it can be the electrical motor failures, it can be battery failures, mean no AC power connected. And the effect will going to happen, your patient will get hypoxic and hypercapnia, and hemodynamically patient get collapse. So if your patient is fully dependent on an ECMO, and your machines is not performing a great function, and you're not achieving the flow which you required through with the support of the ECMO, and the tissues of the patients are not perfused with the adequate oxygenation, so then the effect will come like you will get like hypoxia, you will get sometimes hypercapnia, sometimes your hemodynamic patient collapse, like your saturation will going to be decreased, like with the help of the ECMO your saturation is maintaining a 90 and above, and suddenly by effect of pump failure your oxygenation will go, your saturation will going to decrease from 80 to 70, and where you have the patient will going to be collapsed. So this is the effect of actually the pump failures. What can be the prevention of the pump failures? Number one, always maintain pump head in a safe positions. So usually we will talk about different consoles, as I mentioned in the beginning that my presentation is purely based on education purpose, and we are not going to highlight the name of any manufacturers or any specific devices. So as we all are the perfusionists, and we whatever console we are using, and we should do some prevention methods to keep our pump to be in a functional. So the first point is always maintain a pump head in a safe position. So pump head means like few we have different consoles where we our pump head is different, and the oxygenator is a different part. So in some of the consoles, the pump head and the oxygenator is compact, like in a cardiol we have the compact. But if you're going to talk about the Sventromeg, or if you're going to about the Xenius, or if you're going to about the Rotaflow or other devices, the pump head is separate than the oxygenator. So we make sure that the pump head in a secure sided and in a safe position. It should not going to disengage from the pump, but the pump head should not disengage from the motor. So we have to make sure that the pump head safe in a safe position. Number two, so are your console should be fully with the backup support of the battery. So if your battery is not properly charged, you have to make sure the AC connection and the AC power connection is connected with the AC supply, and you will get it a proper supply of the current, and your battery could be fully charged instead to avoid any volatile situations. And then when console not in use, it need to be plugged into the AC power to recharge the battery, and there is some specific periods of the batteries to be replaced and charged. So this is the responsibility of the ECMO specialist nurse or ECMO specialist perfusionist, who is taking care of the consoles, that you should need to coordinate with your biomedical departments. So when is your ppm due, and when need to be changed the battery replacements and the function of the battery, what is the status of the battery backup of your console. So this is your responsibility to make sure your pump head in a safe position, your console in a safe position, your console is fully backed up with the battery support, and the batteries are fully charged and they're fully in a functions. So these can be minimized by prevention of all these steps. Will going to prevent the pump failures as a perfusionist or as a ECMO specialist nurse or ECMO special physician or whatever responsible. In some of the center they are giving this responsibility to respiratory therapist also. Some of the center they are the one who are taking care of the bedside uh, care of the ECMO sports. So what will going to happen if pump get filled? So mean no flow, no RPMs, and what is your first response? So as a perfusionist or usually as the in the internationally market, what is happening? Perfusionists or physician are the responsible to initiate the ECMO, and we handed over the ECMO patients to the bedside nurses, ECMO special nurses, and they are the one who is around the clock with the patient to manage their parameters and manage the ECMO consoles parameters and numbers. So in case there is a pump failures, the first responsibility of the bedside ECMO nurse or the bedside ECMO physician is to call to the perfusionist and ECMO consultant, number one. Number two, patient's management established with the full ventilation. Number three, management of exam in the circuit. Number four is battery failure, re-establish AC power, commence, and hand cranks. So I'll going to explain now this four step in step by step. So make sure those who are attending this presentation, they can use the pen and copy with them. I will give you time. So in case of your pump failures, there is no RPM and no flow. So what will be your first action? Your first action is to clamp your return line. Clear? Your first action is to clamp your return line. You're getting my voice? Hello? Hello? Anyone respond me,
Yes,
citizen?
yes, we're getting
Okay,
you.
okay.
Yes, sir.
Okay,
Yes,
okay.
Yes, sir.
sir.
Okay, okay, thank you so much. Otherwise, I was thinking maybe I'm the one who's just speaking and no one is there. Okay, thank you so much.
Yes, sir. We are
Thank,
listening you.
thank you. So your first step in case of pump
Yes, sir.
failure mean no RPM, no flow mean your first step is to clamp your return line. Why not access? Now I'll just describe here return and access. So return mean the blood which you're getting from the patient and from the membrane oxygenation and returning back to the patient. What is the access? Access is the patient blue blood which is getting from the patient into the membrane. So we will not use the term here venous or arterial. Keep in your mind. We will not going to use the term venous and arterial. Usually in a bypass surgery we use the venous line and arterial line. But if you talk about the ECMO, ECMO technology or ECMO therapy, so we use the term access and the return. Access is the blood which is getting from the body, and return the blood which is going back into the body. So why we are not using arterial venous, like if you talk about the ECMO, in the ECMO we have V ECMO and we have the VV ECMO. So we can't say this is the venous blood and arterial blood. This can be the access blood and it can be the return blood. Like in a VV ECMO, blue blood which is getting from the IVC is going back into the RA, is not going to the arterial system. It is going into the blue system. So this is the reason we are using the term here, access and the return. So the first step is, in case of any emergency, your first step is to clamp your return line, not access line. I will going to explain why not access, why only the return. And number second is to call for help. First is clamp your return line, because no flow and no RPM, return line is clamp, and call for help. So someone can going to help you. Number two, then the person when who going to call for help, then people team will, the Ecmo team will going to be come to you within a minute. And your first step is to the person who will be the team leader of the group. He will going to, so you have to assign the group. So one will be the time leader who will going to stay back from the patient and going to be order. So one will be the bedside nurse, one can be the CPR team members, and the other with the medication doctor, and the other one is a ventilation support. So they are the different assigned role now here. So you all have to coordinate with your team leader. So one of you will be going to be the team leader. So you once you initiate help, so team will arrive, and one can be the team, one out of the group, one will be the team leader. His responsibility is to give a command and receive the messages, not to intervene in the systems. So for you return, clamp the return line, and then I'm going to clamp the return line. No flow, no RPM, my machine get off. Now the person who's the team leader is going to be command to the people who's taking care of the ventilator from the anesthesia. Usually you know that when patient is on an ECMO, your ventilator support is on a very minimal numbers, very minimal side, like 5, 10, 10, 10, 10. So you are not going to higher side. So now the time is to, you say, increase your ventilation from the patient side, not the ECMO side. So the person who's taking care of the bedside patient side nurse, he will going to be increase the ventilators from the lungs. They'll just start the lung ventilation from there. Okay. The one person who is taking care of the circuit examines. So the person who have to take care, what can be the reason why the circuit get, my machine is not working. So he will going to take help to the person, and he will going to remove the oxygenator from the console. And if you are using, for example, cardio help, so you are going to use the hand crank here. Clear? So when he will going to fix the hand crank on the oxygen membrane oxygen on the hand crank, he will announce, I will going to start the hand crank. Then he will going to release the return line and start hand cranking the patient. And meantime, the person will going to check what is happening with this machine. Is the battery failures or some electrical failures? So in case this is a battery failure or electrical or something, once your patient, your machine is ready, you can go back with the system, and then you can decrease the ventilation support and everything. But in case you are using like a Centrimag, so you know, in a Centrimag, or if you talk about the Genius machine, or if you're using so you can use the battery, not a battery backup, you have the backup pump is available, so you can fix your pump pad on the backup motor. So you can use the other backup console in these situations. So here you divide the rule. Rule of the perfusionist responsible to for the circuit and examine. Nurse is responsible for the bedside medications and ventilation, and CPR team is ready in case of the patient get deterioration and patient's saturation and patient start collapse, because patient was fully dependent on the ECMO. So they can start for the like a CPR in this type of the situation till you resume back or reback your ECMO support to the patients. So usually you will find two type of severe emergency in a extra carpal membrane oxygenator. Number one is a pump failure. Number two is air in the circuit. Okay. So now we'll talk about the air in circuit, or we can say air embolism during the extra carpal circulation sports. So the definition of the circuit air embolism, introduce of air into the circuit. So now, before I'll go with the causes and the effect, I will tell you two things. Like usually in your the extracorporeal circuit, and especially on the membrane, you will find the hydrophobic ports are available. So if you are using if your machine is alarming, sorry, if your machine is alarming, there is a the minor error in the circuit and the flow was not fluctuating and saturation is maintaining, it was not affecting the flow and RPM and the pressures, and even the patient saturation is maintaining, but still your machine is showing like air in the circuit. So in that type of situation, you need to open the hydrophobic port, which we're going to help to remove the minor air in the circuits without any intervention. Just remove the yellow. Usually, like in a cardio valve, you will find a yellow port and the membrane. So remove that yellow port, the yellow connector for 30 minutes. So if there is a minor, it will going to pass out, and within 30 minutes, just close back that yellow cap. Otherwise, if you keep open throughout the your ECMO therapy, that port will going to be clotted with the fibrin, and then you will not able to get de-airing in case of any disasters to situation. So a recommendation is keep that port open for 30 minutes, not more than that. So the dev, as I mentioned, so you can, if there is a minor air, you can just open the hydrophobic port. If you got about talk about the different other oxygenators, and still they were giving you the hydrophobic port disposables ones, you can connect it there. So if you find any micro bubble in your membranes, you can just open that hydrophobic for a couple of like for like a 30 minutes or a couple of minutes, and if the air is moved, you will the alarm will automatically be silenced. So what can be the causes of air in the circuit? Introduce of air into the circuit via peripheral cannulation site or central line, fracture of the connectors, or inlet side of the pumps. Now, air can be enter, especially in the VV ECMO. The most disaster of air is if you are doing the VV ECMO, and if you're going to add an additional cannula, because this is the closed circuit and especially the venous circuit, so there's a chance of to suck more air through that. Air always enter through the access line, not to the return line. In the return side, you have the positive pressures. In the excess, you have the negative pressure. The source of air is in a negative side, not in the positive side. Okay. So usually, what we experience, air can be enter in the system when you need to add another cannula in the venous side. Like you want to increase the frequency of the flow and you drainage, so you can add an additional the second cannula. So there's a chance you can suck the air. Then usually some of the centers they are doing like hemodialysis through the CRT through the circuit, and not even through the circuit, even through the lines they are available in the neck or whatever they are using, and they forgot once they finish the CRT and they forget to stop the three-way, and air can enter in the system in that. So that can be the cause, and sometimes the canal dislodge, or there is a leakages in your connectors, and which can create air entering into the system. And I highlighted here especially, do not allow connector tubings and cannula into to the contact with alcoholic. So don't swipe with your connector and tubing with alcoholic swab. Avoid this, other it can be create a problem for you. What can be the effect if you get air in the system? Massive air embolism into the pump head and stop pumping. Of course, the flow gets start fluctuating. If you get a huge amount of the air, so you're not able to achieve the flow which you required, and it start fluctuating. Number two, patient hemodynamically get collapsed, and you will find the hypoxemia. Introduction of the air embolus into the patients can cause air embolism to the patients, and you can create some patient ischemic from any limb part. So this can be the effect of the circuit of air embolism in case if you are not taking care of the circuit. So this is the reason whenever you come for your in a routine shifts, we always recommend you to start 8 to 8 tip examinations once you take over from the morning shift to the evening shift, or evening shift to the night shift. So do you always take over from A to A's tip examination of the circuit? So A to A means like you start with the access cannula and end up with the return cannula, and you go through and check your whole complete circuit. So what can be the response of air embolism? The response, of course, call perfusionist and ECMO consultant. All disaster I mentioned, always clamp your return line. So once you call for help, call for perfusionist, call for ECMO consultant, clamp your return line, switch off the pump to prevent induction of air into the patient. And number two, here I just want to mention, no need to switch off. Switch off means reduce the RPM. Once you clamp the return line, the blood will not enter to the patients. You just reduce the RPM to zero. For example, your RPM was running like at 2500 to 3000 RPM. So time of when you return clamp the return line, you can just do one thing. You just clamp your return line, reduce the RPM, and assign role of the patient and circuit management. So one will going as we used to do in a previous slide I mentioned. So then as someone will going to assign the roles of to who will going to take care of the patient's circuit, who will taking care of the medication of the patient, who will take care of the like a CPR team, and then we divide the our roles, and one will be going to be the like a consult. Usually, the ECMO consultant will be the team leader, and he will going to assign the role to the group, and they will respond to the consultant, and consultant will respond to them. And oh, thank you so much. See, if you have very good wife, she will going to take care of you. And I got a this is 4 5 o'clock tea time. Okay, thank you, Begum. So everyone have their own assigned role. So patient management. So what will be going to the patient management? Number one is full ventilations. So not one person will do everything, as I mentioned before. So one nurse will be going to take care of the ventilators according to your hospital assigned role. Or some of the centers maybe they are using the respiratory therapist. They are taking care of the ventilator side. Some of the centers there the nurses are taking care, so nurses will going to take, so one nurse will going to start the ventilation, full ventilation, lung ventilation. If air in the patient circulations, position the patient head down to avoid the blood, the air enter into the brain. Inotropic support and maintain the mean arterial pressure. Consider aspiration of the right heart using this existing line. So I will make it in a simple words to you now here. Don't go through with this thing. Number one, when you climb the line, call for help. Team came. Start under the supervision of your team leader. Time. Time is going very fast. Okay, the message. Okay, so it's going too fast. So is it? It will go beyond. It will going to be finished. It so within 40 minutes if the so still 8 minutes we have in case the this present your meeting end. Please rejoin back to us. Okay, so I'll try to finish as fast I can, but in case you can rejoin back if I'm not able to finish fast. So clamp it, return line, call for help. So one person will going to take care of the medications, one person will going to take care of the ventilators, other person will going to take care of the ECMO circuits, so de-airing, and one person will going to take the cause of air, from where we are getting the air. So if you don't find the cause of air into the circuit, otherwise if you're doing the de-airing, it will go back in. So you always keep life start very fast because time is very less. So what you have to do, keep 50 cc 3 cylinder at least 3. Why 3, not less than 3? Because the capacity of usually the oxygenator is 150 mils. So by aspirating, in case of massive air in the air in the membrane, you still can decrease. So clamp return not access. If you're going to clamp the access line, you're not able to suck. It will create more air in the circuit. So clamp the return and not the access line. Put your lever lock syringe on the pre-membrane pigtail, not on the post-membrane pigtail, because you want to de-air. The air should be in the lighter, so always keep the pre-membrane pigtail and suck 50 cc, 50 cc. And once you're sure there is no 50 cc, there is no air, then keep RPM like 1000 RPM and inform to the team I'll going back to full flow, and slowly open the return line and achieve your full flow. So this is the management of air in the circuit, and dear properly and find the source of air. If you will not going to find the source of air, then air will come back again to the circuit. Oxygenator failures. First was the pump failure. Then is the air in the circuit. The third most common issue is you have oxygenator failure. The definition of the oxygenator is the thrombus may be built up in the oxygen over the time, which can lead to decrease the gas exchange function of the membranes. So, what can be the feature of impending the oxygenator failures? The worsening gas exchange, increase your TMP above than 50 millimeter per mercury, decrease the post-oxy PO2, and decrease the oxygen transfer. So number one is once you initiate the ECMO, so you always do the TMP base. Usually you will find in it depend on the oxygenators, like Amidos oxygenators. Like in a cardiac, we are getting like a baseline like within a 16 or 20 millimeter mercury, and we recommend if it go double than the baseline, you can do the change of oxygenate in a elective methods. And number two is your post oxy. Usually the post oxy you will get above than 450 millimeter mercury. So when the trend of the post oxy is coming down, so it will indicate that your oxygenator is going to be filled. And third is you can use the torch and to do the physical examine of the fibrin of all the corners. So if you find that there is a stagnancy of the blood or there is a clot, it will also indicate there is a oxygen. And the number third is the last is a decrease of oxygen transfer. The oxygen transfer formula is very important, and this is a long subject. Actually, we can talk about it. So for example, it depends on the flow and the TMP. So and the flow and according to the temperature. So if your TMP, the gas transfer is decreasing, which we required, so you can change the oxygen in an elective method instead of the volatile in a disaster in an emergency situation. So you can have the MDT meeting among with the physicians, nurse, perfusionists, RT, the team member, and decide to change your oxygenator electively instead of any emergency situations. So what can be the prevention? Number one, daily monitoring area is, as I mentioned, start from the access to till returns. Number two, daily inspection of the membrane, daily pre and post auction, calculation of your gas transfer formula, and proactive changing the circuit rather than the reactive. So these are the preventions method how to prevent any disaster and any volatile situations, especially in a failure of your oxygenators. So as I mentioned, three basics emergencies, ECMO circuit emergency. Number one is your pump failures. Number two is your air in the circuit. Number three is the oxygenator failure. These circuits, I'll try to explain the how to overcome these emergencies and how to prevent these emergencies on your ECMO sports during intensive care management. So number fourth is your accidental decannulation. It is very rare. Is not nowadays very rare. Is because nowadays we are doing so many good things that there is very less chance for decannulation in accidental. So the definition I mentioned, I will start is the partial or complete removal of the either access or return line. The effect can be as routine the hypoxemia, hemodynamical collapse, massive blood loss from the cannula side, and it is very difficult to recannulate back. So we experience if there is a removal, this decannulation in accidental, in ECMO, and to go back to cannulate is not a easy job. It is a tough, very tough, and challenging, and may you can lead to end up with the bad situations. And you should be secure your cannula in a proper method. And what can be the prevention? Fix cannula properly use of the spotter to ensure the lines are free from any obstructions. What will happen? How will you going to respond if there is a accidental decannulation? So response will be call for help, perfusionist and ECMO consult on call, assign the role for the concurrent position and circuit management. Sorry. Patient management, re-establish full ventilation, volume expansion to replace the blood loss. What can the circuit management if the cannula completely remove, clamp your return line, turn off your pump, apply the pressure from the cannula side. If cannula partial remove and no native lung function, push the cannula back till the hole should be covered. And if you are confident, mostly if it's not easy as mentioned, it's not easy to remove the cannula. easy job if you canalize out, and if you already the excess cannula, the port is outside, and you will get a huge amount of air. So now in accidental decannulation, you will find two now scenarios. Number one is air in the circuit, number two the accidental decannulation. So then you need a competent person who can manage properly and keep the patients alive. The conclusion of all my presentation is keep the hand crank at the bedside all the time. And if you're using other console, so conclusion is keep the hand crank at the bedside at all the times. And if you are using like a other consoles like a Centrimac, Xenius, or Rotaflow, or Spectrum. So they have their backup consoles available. So you keep the backup console if there is a backup console, or if you the hand crank, so keep the hand crank with you. It depends on the console. What are you using? Clamp the return line and control the source of the air embolism. Monitor the trend of the TMP. Proactive circuit changes rather than the reactive for the membrane failures. Never wipe the cannula with alcoholic, as I mentioned. Always keep the brakes on at all time, and always be smile and be relaxed. Don't get panic in any Ecmo circuit emergencies, and behave like a professor. Have a nice and very good day, and thank you for listening to me. Hello.
Yeah, I'm still here.
Yes, sir. Any questions?
Yes, Mr. Rajaz.
Yeah. Welcome, Sir Nadir Naved. Yes, sir. Order.
Hmm. Actually, one of the slides you mentioned there is the not avoiding the alcohol for cleaning the
The
circuit.
can
So, what is the reason behind this avoiding contact with the alcohol for the
you
connector?
know very good question. Actually, with alcoholic, we experience, and it was a recommendation by the circuit management that don't wipe. It will make a crack with the alcoholic swipe. The material we are using for to wipe the alcoholic, it can create, by the stiffness of that, it can create a cracks in the on the tubes, and especially in the connectors. And if you're wiping with the connector with the alcoholic soap, so it will going to make a crack in the connector, which can create leakages or cracks, and it can be the source of air to be enter in the circuit. So we recommend personally to everyone, don't use alcoholic swab. If you want to clean your machines, you can use other things like with the other wet soap, with the soaps and the cleanings material detergent, as compared to the alcoholic. Don't use other detergents to clean your tubes and connectors.
Yes, but I agree. But I think the most of the hospital cleaning is spray and the materials, any liquid. I think this some kind of the alcohol is the involved.
Yeah, but there is some percentage of but for especially for the ECMO circuit, we never recommend, and even special for the bypass circuit. In a bypass, doing the bypass, we never recommend that to use alcoholic to wipe the connector, because this is not an 8 hour procedure. This is not like a 5 hour procedure. This tubes will going to be work like maybe 15 days, maybe month, or it can be the couple of months, because this ECMO is not going to be end up within 8 hours. So by using the alcohol on on the tubings on the connectors, and it will going to be used for like a couple of weeks or a couple of months, it can create cracks on the tubes, and which can cause air embolism. If
Actually,
you're
I
using
had this.
if you're using for 2 hours or like a 3 hours is acceptable. But if you're keeping the circuit for like for a couple of weeks or a couple of months, so it is not recommended.
Oh, okay, okay, got it. Uh, if you one of the more question, if you don't mind.
No, please.
Hmm. So, Can you just provide some example of the how the air might be entering the peripheral cannulation sites, so all the central line? If you, especially being a cath lab technologies, because actually some of the ECMO was done, emergency ECMO was done in the cath lab.
Yeah, yeah.
So what is the preventive and what's the
Okay,
cause?
I got your point. Thank you,
Hmm.
Naved, to highlighting this point. You know, for example, I will talk in your territory. You know, usually we are
Hmm.
using the angiovac system in the cath lab. Okay,
Hmm.
sorry,
Okay.
sorry.
Hmm.
Angiovac in the system, and you know we have the closed circuits going on, and we are using angiovac as a, with the rotaflow. And the time when they are going to be add any extra central line, we recommend them to either close or we stop a circuit for a minute, because with that there is a huge chance to we can suck that the time of they insert the dilators. You got my point? Once they put
Yes,
the
yes, yes.
needles, guide wire is okay. Once they start dilating, there is a huge chance we can suck the air. So once you put any lines, we decrease the flow or reduce the RPM. If we are keeping with a higher RPM, the circuit at the time when you are inserting additional any central line, there is a huge chance, and we suck air in the circuit, especially if we are using like a big cannulas, like lead
Hmm.
French 10 French cannula or 17 French cannula. If we need it to edit, although we
Hmm.
are not, then
Hmm.
100% recommendation we have to stop for a couple of minutes, couple of seconds, the time when we are dilating and inserting, to avoid the suctioning. And we experience that we are adding an additional cannula, and the suddenly you the time when he dilated, and we suck all air in the circuit, and then you just start dealing to air in the circuit, and you are going to make it can be create a trouble for the patient, and to get a better outcome. So recommendation, always reduce your RPM flow, or either you can stop ECMO for the like as a circulatory support the time of you're adding additional any line, especially in the
So,
VVC.
so in the cath lab setting, you just informing the our
Like
intervention
if
is trivial.
yeah, we inform to the physician, even your cardiologist. I last time I was in the cath, I told them, please, if you're adding any other line, let me know. I will going to stop for the time you're going to insert this line. And for the arterial, no issue. These are positive pressure, but
Hmm.
for the side, 100% you will going to suck some volume air.
That sound good. I think the beginning of the start of the procedure, I have to tell to the every physician, because actually doctor is changing on the daily basis,
Yeah.
and some of the doctors is in the practice they know they're doing on the daily basis, but actually some of the new doctors they don't know about these things.
Then
They,
you will
this,
buy the
hmm,
new doctor. Then this is your responsibility to tell them
hmm,
the time they're inserting. Then it is your, because you're the senior person. Then you have to tell them, please let me know when you're going to insert a new line. I will reduce the flow, or even I can stop for a couple of minutes. If the patient is tolerated, you can stop even. And usually now physicians are very like cooperative, and they understandable. They know that there is a chance of their sectioning in the time of your putting an additional any central venous sites cannula or line.
thank you very much, Ajaz. Thank you for
Well,
explaining.
brother, any other question?
Yes, it does. I'm gonna come in here and just call